Now let's begin with high-yield facts in musculoskeletal system. Whole body. Common adult orthopedic injuries. Orthopedic injuries affect all populations and often present as a result of trauma or a fall. Understanding the presenting features, diagnostic findings, and management of these common injuries is critical for developing clinical knowledge. The most commonly tested and seen conditions are discussed here. Posterior hip dislocation presents with a shortened, internally rotated leg. Anterior hip dislocation presents with a lengthened, externally rotated leg. Hip fracture presents with a shortened, externally rotated leg. Table outlines the presentation and treatment of orthopedic injuries that commonly affect adults. Upper extremity injury presentation treatment: shoulder and upper arm clavicle fracture occurs after trauma, typically a fall, and presents with pain and possible skin tinting due to fracture angulation. The proximal fragment will be elevated and the distal will be depressed due to muscular pull. There may be accompanying snapping or clicking. Treatment includes a sling if uncomplicated, and surgery if the fracture is open, displaced with skin tinting, or there is neurovascular compromise. Shoulder dislocation may be anterior or posterior. Anterior dislocation is most common, accounting for 95% of cases, and carries a risk for axillary nerve injury. Patients hold the arm in slight abduction and external rotation. Posterior dislocation is rare and is associated with seizure or electrocution. Patients hold the arm in adduction and internal rotation. Treatment involves reduction followed by a sling and swath, while recurrent dislocations may require surgery. Acute rotator cuff tear presents with acute onset anterior shoulder pain and weakness with abduction or external rotation of the humerus after a fall on an outstretched arm or in young athletes. Significant shoulder stiffness may occur in patients with dermatomyositis. Diagnosis can be made clinically and confirmed with MRI. Treatment involves rest and nonsteroidal anti-inflammatory drugs for minor injuries, while surgery is indicated if there is loss of active range of motion with preserved passive range of motion. Humerus fracture results from direct trauma and may lead to nerve injury if fractured proximally affecting the axillary nerve, midshaft affecting the radial nerve, or distally affecting the median or ulnar nerve. Treatment includes a coaptation splint if uncomplicated and surgery if the fracture is open or significantly displaced. Upper extremity injuries. Forearm injuries. Nightstick fracture. The nightstick fracture refers to an isolated fracture of the ulnar shaft, usually caused by direct trauma. It's often seen when someone raises their arm to protect themselves from a blow, much like using a nightstick as a shield. Patients present with pain and swelling along the forearm and sometimes visible deformity. Treatment is usually conservative with immobilization in a cast if the fracture is uncomplicated. However, if the fracture is open or significantly displaced, surgical repair is required. Monteggia fracture. The Monteggia fracture involves a diaphyseal fracture of the proximal ulna accompanied by dislocation of the radial head. This injury often results from a fall on a pronated, outstretched arm or during a defensive movement similar to a nightstick injury. Patients typically present with forearm pain, limited elbow movement, and deformity. Management requires open reduction and internal fixation, ORIF, of the ulnar shaft, followed by a closed reduction of the radial head. Early intervention ensures proper joint alignment and prevents long-term dysfunction. Galeazzi fracture. The Galeazzi fracture is a diaphyseal fracture of the radius with dislocation of the distal radioulnar joint. It commonly results from a direct blow to the forearm or a fall on an outstretched arm. Clinically, patients have wrist pain, forearm tenderness, and sometimes obvious deformity near the wrist. Treatment involves open reduction and internal fixation of the radius, followed by immobilization of the forearm and supination to maintain reduction of the distal radioulnar joint. Wrist and hand injuries. Cole's fracture. The Cole's fracture is a distal radius fracture that typically occurs when a person falls onto an outstretched hand with the wrist extended, also known as a Fuchs injury. This leads to a dorsally displaced and dorsally angulated fracture, often described as a dinner fork deformity. It's most common in older adults with osteoporosis and in children. Treatment begins with a closed reduction, followed by a short arm cast to maintain alignment. Surgery is required if the fracture is open, displaced, or involves the joint surface. Scaphoid fracture. The scaphoid fracture is the most frequently fractured carpal bone and typically results from a fall on an outstretched hand. Because the fracture may not immediately appear on X-rays, clinical suspicion is crucial, particularly when there is tenderness in the anatomic snuff box. If a fracture is suspected, immobilization in a thumb spica cast is started right away, followed by serial X-rays for confirmation. Displaced or non-union fractures require open reduction and internal fixation. It's important to note that disruption of the scaphoid's retrograde blood supply can lead to avascular necrosis, especially in proximal or displaced fractures and in smokers. Boxer's fracture. A boxer's fracture refers to a fracture of the fifth metacarpal neck, commonly caused by striking a hard object with a closed fist, such as punching a wall. The hand typically swells, and the knuckle may appear sunken. Treatment involves closed reduction and splinting, but surgery is indicated if the fracture is severely angulated, rotated, unstable, or if multiple metacarpals are involved. De Quervain tenosynovitis. De Quervain tenosynovitis is an inflammation of the tendons along the thumb side of the wrist. It often occurs in new parents who frequently lift their babies with outstretched thumbs or in individuals who use handheld devices extensively. The hallmark finding is pain during the Finkelstein test, where the thumb is folded into the palm and the wrist is moved toward the ulnar side. Treatment begins with rest, NSAIDs, ice, and a thumb spica splint. If symptoms persist, corticosteroid injections can provide relief. Lower extremity injuries. Hip dislocation. Among lower extremity injuries, hip dislocations are particularly significant because they are orthopedic emergencies. Posterior dislocation is by far the most common, accounting for over 90% of cases. It usually occurs from a strong posteriorly directed force on a flexed, internally rotated, and adducted hip, such as when a driver's knee hits the dashboard during a car crash. This injury can damage the sciatic nerve and is associated with a high risk of avascular necrosis of the femoral head. In contrast, anterior dislocation occurs when the hip is forced into external rotation and abduction, such as during a fall or a direct blow to the inner thigh. This may injure the obturator nerve. Treatment for both types of hip dislocation is emergent closed reduction, unless there is associated pathology requiring open surgery. After reduction, a CT scan is performed to confirm proper joint alignment and to rule out fractures. In terms of appearance, an anterior dislocation presents with the leg abducted, extended, and externally rotated, while a posterior dislocation presents with the leg adducted, slightly flexed, and internally rotated. Hip fracture risk increases with osteoporosis and presents with a shortened and externally rotated leg. It can be radiographically occult, so a good clinical history with negative X-rays warrants further evaluation with CT or MRI. Displaced femoral neck fractures are associated with an increased risk for avascular necrosis and non-union and may also lead to deep venous thrombosis. The injury involves the acetabulum and or proximal intracapsular femur. Treatment includes open reduction and internal fixation, with displaced femoral neck fractures often requiring hip hemiarthroplasty or total arthroplasty. Anticoagulation is used to reduce the likelihood of DVT. Femoral fracture results from direct trauma and has an increased risk with long-term bisphosphonate use. It can be complicated by fat emboli, which present with fever, changes in mental status, dyspnea, hypoxia, petechiae, and decreased platelets. Treatment involves open reduction and internal fixation, as well as irrigation and debridement for open fractures. Knee ligament injuries present with immediate pain, significant swelling, instability, and hematoma. Anterior cruciate ligament injury results from a non-contact twisting mechanism, force hyperextension, or impact to an extended knee, and shows a positive anterior drawer and Lockman test. Medial collateral ligament injury shows a positive valgus stress test, while lateral collateral ligament injury shows a positive Vera stress test. Posterior cruciate ligament injury results from a posteriorly directed force on a flexed knee, such as a dashboard injury, and shows a positive posterior drawer test. Meniscal tears result from an acute twisting injury or degenerative tear in older adults, often with clicking, catching, or locking. Examination reveals joint line tenderness and a positive McMurray test, and MRI is the diagnostic test of choice. Treatment for ACL tears typically involves surgical repair in symptomatic, young patients, while older patients are often treated non-operatively. Meniscal tears are repaired in younger patients with reparable tears or removed through meniscectomy if repair fails. In older patients with mechanical symptoms who do not respond to conservative therapy, removal is performed. Tibial stress fracture. A tibial stress fracture presents with localized point tenderness along the tibia that worsens with physical activity and improves with rest. It's frequently associated with factors such as malalignment, abnormal foot arches, and the female athlete triad, which includes disordered eating, amenorrhea, and decreased bone density. The differential diagnosis includes shin splints, medial tibial stress syndrome, which are typically seen in more casual or overweight athletes, as well as compartment syndrome. Initial X-rays may appear normal, which makes early diagnosis challenging. Treatment depends on the severity. Non-operative management includes activity modification, rest, and sometimes casting to allow bone healing. Operative treatment, such as intramedullary nailing or open reduction and internal fixation, ORIF, is considered in cases of non-union or persistent pain due to the increased risk of incomplete healing. Achilles tendon rupture. An Achilles tendon rupture is a dramatic injury that usually presents with a sudden pop or snapping sensation in the back of the calf, followed by pain and difficulty walking. It often occurs in individuals with poor physical conditioning or in those taking fluoroquinolone antibiotics like ciprofloxacin, which can weaken the tendon. Patients exhibit limited plantar flexion and a positive Thompson test, where squeezing the calf fails to cause the foot to flex downward. Treatment depends on the patient's activity level. Elite athletes are usually treated surgically, followed by casting, as this allows a quicker return to physical activity. Non-athletes or lower-demand individuals can often be managed conservatively with immobilization and gradual rehabilitation. Popliteal Baker cyst rupture. A popliteal cyst, also known as a Baker's cyst, results from the extrusion of synovial fluid into the gastrocnemius or semimembranosus bursa. It often develops in individuals with underlying arthritis or chronic joint inflammation. When the cyst ruptures, it may cause sudden pain and swelling in the calf, sometimes mimicking a deep vein thrombosis, DVT. The patient may notice a painless bulge behind the knee and, occasionally, tibial nerve palsy or a distinctive crescent sign, a patch of bruising around the medial malleolus. Diagnosis is confirmed through ultrasound, primarily to rule out DVT. Treatment involves nonsteroidal anti-inflammatory drugs, NSAIDs, rest, and activity modification. Surgery is reserved for persistent or symptomatic cases that do not respond to conservative therapy. Ankle and foot injuries. Ankle fracture. An ankle fracture typically results from a fall or twisting injury involving inversion or eversion of the foot. It can be confused with an ankle sprain, so it's important to apply the OTTAWA ankle rules to determine if an X-ray is necessary. Treatment depends on severity. Stable fractures are managed conservatively with casting and limited weight bearing. Open, displaced, or unstable fractures require open reduction and internal fixation, ORIF, to restore proper alignment. Calcaneal stress fracture. A calcaneal stress fracture presents as pain at the base of the heel or posterior foot, often reproduced by direct compression of the calcaneus. It is common in runners and military recruits who perform repetitive impact activities. Treatment is conservative and includes rest, reduced activity, and gradual return to training once symptoms resolve. Metatarsal stress fracture. Metatarsal stress fractures occur due to repetitive strain or a sudden increase in physical activity. They are especially common among female athletes and military recruits. The second metatarsal is the most frequently affected bone. Patients experience localized forefoot pain that worsens with activity. Most cases are managed conservatively with rest and supportive footwear. However, fractures of the fifth metatarsal, especially at the base, have a higher risk of nonunion and therefore may require casting or surgical fixation, or if. Key fact: the classic unhappy triad of knee injury involves damage to three major structures: the anterior cruciate ligament, ACL, the medial collateral ligament, MCL, and the medial meniscus. However, in acute ACL injuries, lateral meniscal tears are actually more common than medial ones. The unhappy triad of knee injury. The unhappy triad, also known as the terrible triad of a knee, is a classic sports-related injury pattern. It involves simultaneous damage to three key structures: the anterior cruciate ligament, ACL, the medial collateral ligament, MCL, the medial meniscus, MM. This triad most commonly occurs when a valgus force, meaning an inward force, is applied to the knee while the foot is planted on the ground. This twisting motion causes the ACL to tear first, followed by injury to the MCL and the medial meniscus. Patients usually present with a popping sound at the time of injury, followed by immediate swelling, knee instability, and difficulty bearing weight. Prompt evaluation and MRI are essential for diagnosis, and treatment may range from physical therapy to surgical repair, depending on the severity. A key point to remember is that while the unhappy triad traditionally includes the medial meniscus, lateral meniscal tears are actually more commonly seen in modern sports-related ACL injuries. OTTAWA ankle rules. When a patient presents with ankle pain after a fall or twist, it's not always clear whether an X-ray is needed. The OTTAWA ankle rules were developed to help clinicians make that decision, reducing unnecessary radiation exposure while ensuring serious injuries are not missed. Here's the simplified version. If the patient cannot walk 4 steps immediately after the injury, and in the emergency department, get an X-ray. If there is tenderness on palpation at the malleolar zone, either at the medial malleolus or lateral malleolus, get an X-ray. Additionally, if there is pain in the midfoot region, specifically over the navicular bone or the proximal fifth metatarsal, a foot X-ray is indicated. These guidelines help distinguish between cases that may simply need rest and ice versus those requiring imaging and orthopedic evaluation. In short, if the pain is deep, persistent, or limits weight bearing, don't just walk it off, get the X-ray. Salter-Harris pediatric fracture classification. In children, fractures can involve the growth plate, or physis, an area of developing cartilage tissue near the ends of long bones. Because damage to this region can affect future bone growth, pediatric fractures are classified using the Salter-Harris system, which helps predict long-term outcomes. There are 5 primary types, remembered easily with the mnemonic SALTER, which stands for S. Straight across the growth plate, type 1. A. Above the growth plate through the metaphysis, type 2. L. Lower or below the growth plate, extending into the epiphysis, type 3. T. Through the metaphysis, physis, and epiphysis, type 4. ER. Erased or rammed, meaning the growth plate is crushed or compressed, type 5. Let's describe each type briefly. Type 1. The fracture line passes straight across the physis without compressing it. A classic example is slip capital femoral epiphysis, SCFE. Type 2. The fracture crosses both the metaphysis and the physis. This is the most common type. Type 3. The fracture passes through the physis and into the epiphysis, involving the joint surface. Type 4. The fracture line cuts through all three regions, metaphysis, physis, and epiphysis, potentially disrupting normal growth and joint alignment. Type 5, the rarest and most severe type, where the growth plate is crushed or compressed, leading to growth arrest and a poor prognosis. The Salter mnemonic, slipped, above, lower, through, erased, or rammed, is a simple and effective way to recall this classification and its implications for prognosis and management. Common peripheral nerve injuries. The brachial plexus and its many nerves are high yield, both as clinical knowledge and commonly tested concepts. Often you will be required to trace symptoms to nerve lesions based on symptoms and exam alone. Clinical presentations with their associated nerves. Common peripheral nerve injuries. Long thoracic nerve injury. The long thoracic nerve plays a vital role in allowing you to lift your arm above your head. It powers the serratus anterior muscle, which helps keep the scapula, the shoulder blade, flat against the chest wall and allows the arm to be lifted above 90 degrees. Motor deficit. The patient loses the ability to fully abduct the arm above shoulder level. Sensory deficit. None, since the long thoracic nerve is purely motor. Common causes. Damage often occurs during axillary lymph node dissection, chest tube placement, or a stab wound to the axilla. Clinical findings. The classic presentation is the winged scapula. When a patient presses their hands against a wall, the shoulder blade visibly lifts or wings away from the thoracic wall. This finding is so characteristic that it almost always points to long thoracic nerve injury. Radial nerve injury. The radial nerve is the great extensor of the arm. It controls wrist, finger, and thumb extension. When injured, the patient can no longer extend the wrist, leading to a classic wrist drop. Motor deficit. Loss of wrist, finger, and thumb extension. Sensory deficit. Numbness or tingling over the dorsal forearm and the back of the hand, particularly over the first 3.5 fingers, thumb, index, middle, and part of the ring finger. Common causes. Midshaft humeral fractures, which can directly damage the nerve as it spirals around the bone. Prolonged compression of the arm, such as when sleeping with the arm over a chair, commonly known as Saturday night palsy. Radial head subluxation or repetitive pronation and supination at the elbow, which can injure the nerve distally. Clinical findings. Proximal injury leads to wrist drop with accompanying sensory loss. Distal injury affects only the fingers, causing finger drop without sensory deficits. This distinction is crucial. Wrist drop with numbness points to a higher level lesion, while finger drop alone means a lower level radial nerve issue. Median nerve injury. The median nerve is responsible for fine movements of the hand, particularly the thumb, and contributes to wrist flexion and finger flexion. It's often remembered as the nerve that allows you to perform delicate tasks like writing, buttoning a shirt, or pinching objects. Motor deficit. Weakness in forearm pronation, wrist flexion, and thumb opposition, bringing the thumb to touch the fingertips. Sensory deficit. Loss of sensation over the palmar surface of the first 3.5 fingers, the thumb, index, middle, and half of the ring finger. Common causes. Supracondylar fracture of the humerus in children, causing a proximal lesion. Carpal tunnel syndrome, compressing the median nerve at the wrist, leading to a distal lesion. Clinical findings. In proximal injury, the patient shows weak wrist flexion, a flattened thenar eminence, and difficulty forming certain hand gestures. In proximal injury, when asked to make a fist, the first 3 fingers fail to flex, producing the hand of benediction or sometimes the OK sign abnormality when the thumb and index finger can't form a circle. In distal injury, as seen in carpal tunnel syndrome, the patient develops a median claw deformity when attempting to extend the fingers. The thumb, index, and middle fingers remain flexed. Ulnar nerve. Motor deficit includes loss of finger abduction. Sensory deficit involves the palmar and dorsal surface. Ulnar nerve. Motor deficit includes loss of finger abduction. Sensory deficit involves the palmar and dorsal surface of the last 2.5 fingers. Common causes include hook of hamate fracture or Guyon canal syndrome for distal injury, and elbow dislocation or entrapment at the medial epicondylar groove of the humerus for proximal injury. Clinical findings show an ulnar claw deformity when extending the fingers, along with lack of finger adduction and abduction. Musculocutaneous nerve. Motor deficit affects elbow flexion and forearm supination. Sensory deficit occurs over the lateral forearm. Common causes include shoulder dislocation and trauma to the anterior biceps. Clinical findings show absent biceps reflex and weak elbow and shoulder flexion. Axillary nerve. Motor deficit causes difficulty in arm abduction. Sensory deficit presents as decreased sensation over the deltoid region, also known as the regimental badge area. Common causes are anterior shoulder dislocation and fracture of the surgical neck of the humerus. Clinical findings include difficulty abducting the arm beyond 15 degrees and a flattened deltoid muscle. Common peroneal nerve. Motor deficit involves loss of dorsiflexion and eversion. Sensory deficit affects the dorsal foot and lateral leg. Common causes include knee dislocation, prolonged immobilization, such as crossing the legs, and trauma to the fibula. Clinical finding is foot drop. Superior gluteal nerve. Motor deficit affects hip abduction. There is no sensory deficit. Common causes include weakness of the gluteus medius or minimus muscles. Clinical finding is dropping of the contralateral pelvis below horizontal while walking, known as a positive Trendelenburg sign. Tibial nerve. Motor deficit includes loss of foot inversion and plantar flexion. Sensory deficit involves the sole of the foot. Common causes are trauma to the knee, Baker cysts, or tarsal tunnel syndrome in distal lesions. Clinical finding is a positive Tinel sign at the tarsal tunnel. Obturator nerve. Motor deficit causes loss of thigh adduction. Sensory deficit affects the distal medial thigh. Common causes are pelvic lymph node dissection or pelvic tumors. Clinical finding is a wide-based gait. Femoral nerve. Motor deficit includes weakness of hip flexion and knee extension. Sensory deficit involves the anteromedial thigh and the medial side of the leg and foot via the saphenous nerve. Common causes are direct trauma or prolonged pressure on the nerve, such as from lithotomy positioning. Clinical finding is an abnormal knee reflex. Lateral femoral cutaneous nerve. There is no motor deficit. Sensory deficit involves the lateral thigh, known as meralgia paresthetica. Common causes include iatrogenic compression during surgeries, IVC filter replacement, obesity, or tight clothing. Clinical finding is abnormal sensation of the thigh. Radial, median, and ulnar nerve lesions can be distinguished by specific motor and sensory examinations. For the radial nerve, motor testing involves thumb extension against resistance, while sensory examination assesses the dorsal aspect of the hand. The ulnar nerve is evaluated by testing finger abduction against resistance and checking sensation on the palmar aspect of the hand. The median nerve is tested by assessing finger flexion and palmar sensation. Complex regional pain syndrome is a pain condition associated with loss of function and autonomic dysfunction, typically following trauma, and is not linked to true nerve injury. The disease progresses through 3 phases. The acute or traumatic phase involves the initial development of pain. The dystrophic phase is marked by progression of soft tissue edema and muscle wasting. The atrophic phase results in limited movement, contracted digits, and trophic skin changes. Radiographs in this stage show severe demineralization of bones. Median nerve injury leads to the benediction sign, characterized by an inability to close the first through third digits, while ulnar nerve injury causes the claw hand, marked by an inability to open the fourth and fifth digits. Clinically, complex regional pain syndrome presents with diffuse pain that is disproportionate to the initial injury and often occurs in a non-anatomic distribution. The pain is unrelated to the timing of the initial trauma. Patients also experience loss of limb function and sympathetic dysfunction, which may manifest as changes in skin, soft tissue, or blood flow. Variations in skin temperature, hair growth, and nail growth may occur, and edema is often present. Diagnosis is primarily clinical, supported by objective evidence, such as changes in skin hypersensitivity to touch or temperature, and visible alterations in skin color, hair growth, or nail growth. Treatment for nerve injuries and complex regional pain syndrome begins with nonsteroidal anti-inflammatory drugs, NSAIDs, along with physical and occupational therapy. Additional medications, such as oral corticosteroids, low-dose tricyclic antidepressants, gabapentin, pregabalin, and calcitonin may be used, although no single oral agent is consistently effective. Chemical sympathetic blockade can help relieve persistent symptoms, and referral to a chronic pain specialist is recommended for complex or refractory cases. Osteosarcoma, though rare overall, is the most common primary malignant bone tumor in children and adolescents. It typically arises in the metaphyseal regions of long bones, especially the distal femur, proximal tibia, and proximal humerus. The tumor frequently metastasizes to the lungs. Osteosarcoma has a bimodal age distribution, occurring primarily in young adults and again in patients over 65 years of age. In older patients, risk factors include prior radiation exposure, Paget disease of bone, Li-Fraumeni syndrome, and familial retinoblastoma. Benign bone tumors include several distinct types with characteristic radiologic and clinical features. Enchondroma appears on X-ray as a lytic lesion, often found in the hand or foot of a young adult, sometimes with a family history of Allier disease or Maffucci syndrome. Management involves serial monitoring with X-rays. Giant cell tumor shows a soap bubble appearance on X-ray, commonly affects young adults, and may be associated with Paget disease of bone. Treatment involves denosumab therapy. Osteoblastoma typically occurs in the spine and measures more than 2 centimeters. Patients often describe pain that does not improve with NSAIDs, classically referred to as blasted in the back. Treatment involves surgical resection, with chemotherapy or radiation depending on tumor margins. Osteochondroma projects outward from the growth plate, often found incidentally in young males under 25 years of age, and requires serial monitoring by X-ray. Osteoid osteoma typically affects long bones, such as the tibia or fibula, and is usually small, less than 2 centimeters. It occurs mostly in young males under 25 years of age and presents with pain that does not improve with NSAIDs. Treatment is generally conservative, though resection may be needed if symptoms persist or NSAIDs are intolerable. Malignant bone tumors include Ewing sarcoma, chondrosarcoma, and osteosarcoma. Ewing sarcoma presents as a large, permeative lesion appearing aggressive on imaging, with lamellated periosteal reactions. It usually affects long bones or the pelvis in adolescent males under 15 years of age. Treatment involves surgical resection, often combined with radiation or chemotherapy. Chondrosarcoma produces a moth-eaten appearance on X-ray and may develop from malignant transformation of a pre-existing osteochondroma or enchondroma. Treatment includes resection with possible adjunct radiation or chemotherapy. Osteosarcoma shows a Codman triangle or sunburst pattern on X-ray and typically affects teenagers or older adults with a history of Paget disease of bone or prior radiation. The mainstay of treatment is surgical resection followed by chemotherapy. Clinically, osteosarcoma presents with progressively worsening pain that may become intractable and is often worse at night. Constitutional symptoms such as fever, weight loss, and night sweats may accompany the disease. On examination, erythema and enlargement over the affected site are common findings. Clinical case. A 55-year-old man with a history of prostate cancer presents with low back pain, LBP, and bilateral leg weakness. On examination, he is found to have point tenderness on the lumbar spine and decreased sensation in his legs. What is the best next step? The best next step would be to obtain an MRI. MRI is the best study, but preventing permanent neurologic disability is the priority. Remember to consider multiple myeloma, which can present almost identically. Treatment is to administer steroids to relieve spinal cord compression resulting from likely bone metastasis. Diagnosis begins with X-rays, the best initial test for suspected bone malignancy. X-rays can reveal a Codman triangle, indicating periosteal new bone formation at the diaphyseal end of a lesion, or a sunburst pattern, both classic for osteosarcoma. These findings contrast with the multilayered onion skinning appearance typical of Ewing sarcoma and the soap bubble appearance seen in giant cell tumor of bone. The most accurate diagnostic test is a bone biopsy, while MRI and PET-CT or bone scan are used for staging and comprehensive evaluation. Key fact: the most common benign bone tumor is osteochondroma, which typically presents as a painless mass and usually requires no treatment, only serial monitoring with X-rays. Treatment for osteosarcoma includes limb-sparing surgical procedures along with preoperative and postoperative chemotherapy, for example, methotrexate, doxorubicin, cisplatin, ifosfamide. Amputation possibly necessary. Septic arthritis is an infection of the joint space that most commonly occurs following an open injury or via hematogenous spread during bacteremia. History and physical examination. Patients typically present with a warm, red, and immobile joint. Palpable effusions may be present, and systemic symptoms such as fever and chills can occur if bacteremia is present. A hallmark feature is intense pain with brief joint movement, known as the short arc sign, and patients are usually unable to bear weight. Prosthetic joints significantly increase risk. Other risk factors include recent trauma, underlying joint disease, e.g., gout, rheumatoid arthritis, or osteoarthritis, older age, recent intra-articular injections, and bacteremia from conditions such as endocarditis or intravenous drug use. Diagnosis. The most accurate test is joint aspiration with synovial fluid analysis. Synovial fluid characteristics vary depending on the underlying pathology. Normal, clear, high viscosity, WBC less than 200 mm superscript 3, PMN less than 25%, glucose equal to serum. Non-inflammatory, yellow, high viscosity, WBC 0, 1000 mm superscript 3, PMN less than 25%, glucose equal to serum. Inflammatory, yellow, low viscosity, WBC 1000, 10,000 mm superscript 3, PMN greater than or equal to 50%, glucose greater than 25 mg DL. Examples include rheumatoid arthritis or crystal-induced arthritis. Septic, yellow-green, variable viscosity, WBC 10,000, 100,000 m superscript 3, PMN greater than or equal to 75%, glucose less than 25 mg DL, culture often positive. Arthrocentesis is performed to analyze synovial fluid and differentiate types of arthritis and joint pathology. Crystals can be identified using polarized light microscopy. In pseudogout, crystals are rhomboid-shaped, blue, and show positive birefringence. In gout, crystals are needle-shaped, yellow, and show negative birefringence. White blood cell, WBC, counts in synovial fluid help classify the type of arthritis. Non-inflammatory arthritis, such as osteoarthritis, shows WBC counts less than 2,000 per mm superscript 3. Inflammatory arthritis, such as rheumatoid arthritis, has WBC counts between 2,000 and 10,000 per mm superscript 3. Septic arthritis is characterized by WBC counts greater than 10,000 per mm superscript 3, with cultures often positive for pathogens. Other findings, such as hemorrhagic fluid or fat droplets, may indicate fracture or traumatic joint injury. This evaluation allows clinicians to distinguish between crystal-induced arthritis, infection, inflammation, and trauma, guiding appropriate treatment. Arthrocentesis and synovial fluid analysis are essential tools for diagnosing inflammatory joint pathology. The characteristics of the fluid, including color, crystal content, and WBC count, help determine the underlying cause. In septic arthritis, the synovial fluid WBC count is typically greater than 50,000 mm superscript 3, and gram stain or culture may reveal the causative organism. The most common pathogens include Staphylococcus aureus, Streptococcus species, and gram-negative rods. Risk factors and history can help guide empiric treatment. For example, Staphylococcus aureus commonly affects middle-aged or older adults and is treated with vancomycin. Neisseria gonorrhoeae typically affects sexually active young adults and presents with synovitis, tenosynovitis, and dermatitis. Treatment is with a third-generation cephalosporin. Haemophilus influenza affects children under 2 years or those with sickle cell disease and is treated with a third-generation cephalosporin. Salmonella infections, often in patients with sickle cell disease, are also treated with a third-generation cephalosporin. Treatment: empiric ceftriaxone and vancomycin initially until culture test results, then modification of therapy for specific organisms. Septic arthritis is considered a surgical emergency. Septic joints are considered surgical emergencies and are treated with joint drainage or debridement. Delay in treatment may lead to permanent joint destruction. Key fact: any patient presenting with a red, hot, and swollen joint should have joint aspiration arthrocentesis to rule out septic arthritis. Clinical case: a 15-year-old youth presents with several months' history of pain in the upper part of his thigh. The pain is worse at night. A plain film shows a small lucinitis. What over-the-counter, OTC, remedy is indicated? This adolescent patient is likely presenting with osteoid osteoma, a benign bone-forming tumor characterized by prostaglandin formation. Relief of pain is thus often achieved with NSAIDs. Tumors may resolve on their own, but surgical removal of the nidus may be necessary for symptom relief. Key fact: in sexually active individuals with joint pain, consider the diagnosis of gonococcal septic arthritis. Neisseria gonorrhoeae septic arthritis can present with asymmetric oligoarthritis, tenosynovitis, and skin rash. Osteomyelitis is a bone infection that can occur through direct spread from an adjacent soft tissue infection, which accounts for approximately 80% of adult cases, or via hematogenous seeding, more common in children and in patients who use injectable drugs. Hematogenous osteomyelitis in children typically involves the metaphysis of long bones, whereas in intravenous drug users, it often affects the vertebral bodies. Common pathogens vary based on patient characteristics. In patients with no risk factors, Staphylococcus aureus is most common. Intravenous drug users may develop infections from S. aureus or Pseudomonas. Patients with sickle cell disease are prone to salmonella. Hip replacement infections are often caused by Staphylococcus epidermidis. Foot puncture wounds are commonly infected by Pseudomonas. Chronic infections may involve S. aureus, Pseudomonas, or Enterobacteriaceae, and diabetic patients often have polymicrobial infections including Pseudomonas, S. aureus, Streptococci, and anaerobes. Osteomyelitis in patients with diabetes should be treated with antibiotics targeting gram-negative organisms and anaerobes. Patients typically present with localized bone pain and tenderness, along with warmth, swelling, erythema, and limited motion of the adjacent joint. Systemic symptoms such as fever and chills may be present, and purulent drainage can occur. Laboratory studies often show leukocytosis and elevated inflammatory markers, including erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. Blood cultures may be positive. Imaging is essential for diagnosis. Initial X-rays are often normal, but may show periosteal elevation within 10 to 14 days. Bone scans are sensitive but lack specificity. MRI is the test of choice, showing increased signal in the bone marrow and associated soft tissue infection. The most accurate diagnostic test is bone aspiration with gram stain and culture, although probing through soft tissue to bone is often sufficient clinically, as aspiration carries a risk of spreading infection. Treatment requires surgical debridement of necrotic, infected bone followed by intravenous antibiotics for 4 to 6 weeks. Empiric antibiotic therapy is guided by the suspected organism and gram stain results. Options include clindamycin plus ciprofloxacin, ampicillin sulbactam, or oxacillin nafcillin for methicillin-sensitive Staphylococcus aureus, MSSA. Vancomycin for methicillin-resistant S. aureus, MRSA, or ceftriaxone or ciprofloxacin for gram-negative bacteria. Complications of osteomyelitis can include chronic osteomyelitis, sepsis, and septic arthritis. Long-standing chronic osteomyelitis with a draining sinus tract may eventually lead to squamous cell carcinoma, known as a marginal ulcer. Key fact: penicillin and cephalosporins have minimal cross-reactivity. If a patient had an allergic rash to penicillin, cephalosporins are considered safe. If a patient had an anaphylactic reaction or developed angioedema while on penicillin, use a non-beta-lactam antibiotic. Clinical case: an 11-year-old boy with a history of multiple hospitalizations for pain crises, all related to his sickle cell anemia, presents with fever and severe pain in his right hand. Physical examination shows an area of redness, tenderness, and swelling near the right second metacarpal. Laboratory results show leukocytosis and an elevated erythrocyte sedimentation rate, ESR. MRI shows an area of intensity in the painful area. What pathogen is the most likely cause of his condition? Salmonella is the most likely pathogen causing the patient's condition. Staphylococcus aureus is the most common cause in patients without sickle cell disease and is the second most common organism that causes osteomyelitis in patients with sickle cell disease. Osteoarthritis is a common chronic, non-inflammatory arthritis that affects the synovial joints. It is characterized by the gradual deterioration of articular cartilage along with the formation of osteophytes, or bony outgrowths, at the joint surfaces. The primary risk factors for developing osteoarthritis include increasing age, female sex, prior joint trauma, joint malalignment, sedentary lifestyle, family history, obesity, and a personal history of joint injury. Osteoarthritis is classified as primary when no specific underlying cause is identified, whereas secondary osteoarthritis arises due to predisposing conditions such as prior trauma, avascular necrosis, AVN, inflammatory arthritis, or osteochondritis dissecans. Osteoarthritis can be distinguished from rheumatoid arthritis based on clinical history, pattern of joint involvement, laboratory findings, and treatment approach. Osteoarthritis typically affects older adults and has a slow, progressive onset. The pain worsens with use and improves with rest, and morning stiffness is brief, usually lasting less than 30 minutes. In contrast, rheumatoid arthritis often affects younger individuals and presents with prolonged morning stiffness that improves with activity. Osteoarthritis commonly involves the distal interphalangeal DIP joints, proximal interphalangeal PP joints, first carpometacarpal CMC joints, hips, and knees. When it affects the hands, it may appear symmetric, but elsewhere it tends to be asymmetric. Rheumatoid arthritis, on the other hand, classically involves the wrists, metacarpophalangeal MCP joints, ankles, knees, shoulders, hips, and elbows, and it usually presents in a symmetric distribution. In synovial fluid analysis, osteoarthritis typically shows a white blood cell count of less than 2,000 cells per cubic millimeter, reflecting its non-inflammatory nature. Imaging studies often reveal joint space narrowing and the presence of osteophytes. In rheumatoid arthritis, Synovial fluid shows an inflammatory profile with white blood cell counts between 2,000 and 50,000 cells per cubic millimeter. Treatment for osteoarthritis focuses on symptom relief and maintaining joint function. The mainstays of therapy include physical therapy, nonsteroidal anti-inflammatory drugs, NSAIDs, intra-articular corticosteroid injections, and, in advanced cases, surgery. In contrast, rheumatoid arthritis requires disease-modifying antirheumatic drugs, DMARDs, often used in combination with NSAIDs or glucocorticoids for symptom control or as a bridge to DMARD efficacy. Patients with osteoarthritis typically present with joint crepitus, decreased range of motion, and pain that worsens with activity and weight-bearing but improves with rest. Morning stiffness is brief, lasting less than 30 minutes. But stiffness may also occur after periods of inactivity, a phenomenon referred to as gelling. Characteristic bony enlargements known as Heberden nodes appear on the distal interphalangeal (DIP) joints, while Bouchard nodes form on the proximal interphalangeal (PIP) joints. There is a minimal role for opioid medications in the treatment of osteoarthritis because the potential risks, including dependence and side effects, generally outweigh the benefits. However, in cases of severe, refractory pain where surgical intervention is not an option or is declined, weak opioids, such as tramadol, may be considered as part of the management plan. Diagnosis of osteoarthritis is primarily clinical, supported by imaging. X-rays typically demonstrate joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral bone cysts. It is important to note that radiographic severity does not always correlate with the degree of symptoms experienced by the patient. Laboratory findings, including inflammatory markers, are usually normal, further differentiating osteoarthritis from inflammatory arthritides, such as rheumatoid arthritis. The best initial treatment includes physical therapy to maintain mobility and strengthen surrounding muscles, along with weight reduction in patients who are overweight or obese. NSAIDs are the most commonly used medications for pain and inflammation control. Intra-articular corticosteroid injections can offer temporary relief for localized pain flares. For patients with advanced disease and severe functional impairment, surgical options such as total joint arthroplasty, hip, knee, or shoulder replacement provide the most definitive treatment. Patients with osteoarthritis are also at increased risk for developing osteoporosis, and this should be considered in long-term management and preventive care planning. Osteoporosis, already discussed in endocrinology chapter. Rheumatoid arthritis is a systemic autoimmune disorder characterized by chronic, destructive, inflammatory arthritis that affects multiple joints in a symmetric pattern. The disease primarily targets the synovial lining of joints, leading to synovial hypertrophy and the formation of pons, an invasive granulation tissue that progressively erodes adjacent cartilage, bone, and tendons. Over time, this process results in joint deformity, loss of function, and chronic pain. The condition most commonly affects women between the ages of 35 and 50, and its exact cause remains unknown. However, both genetic and environmental factors play a role. Risk factors include female sex, smoking, and the presence of the human leukocyte antigen, HLA, DR4 genotype, which is strongly associated with the disease. Key fact: keratoconjunctivitis sicca, secondary to Sjogren's syndrome, is a common ocular manifestation of rheumatoid arthritis. Rheumatoid arthritis typically presents insidiously, beginning with prolonged morning stiffness lasting more than 30 minutes, accompanied by painful, warm, and swollen joints. The arthritis is polyarticular and symmetric, often involving the wrists, metacarpophalangeal, MCP joints, proximal interphalangeal, PIP joints, ankles, knees, shoulders, hips, and elbows. Symptoms persist for more than 6 weeks and progressively worsen without treatment. Rheumatoid nodules, firm, non-tender subcutaneous lumps, may develop over bony prominences and near joints affected by the disease. In advanced stages, characteristic deformities may develop. such as ulnar deviation of the fingers due to hypertrophy of the MCP joints, as well as ligament and tendon deformities, including the swan neck deformity, hyperextension of the PIP joint with flexion of the dip joint, and the boutonniere deformity, flexion of the PIP joint with hyperextension of the dip joint. Other systemic and extraarticular manifestations include vasculitis, atlantoaxial subluxation, which increases the risk of spinal cord injury during intubation, and keratoconjunctivitis sicca if associated with Sjogren syndrome. Rheumatoid arthritis typically spares the lumbosacral spine, distinguishing it from other arthropathies such as ankylosing spondylitis. Key fact: rheumatoid arthritis is associated with several distinct syndromes. Feltes syndrome, the triad of rheumatoid arthritis, splenomegaly, and neutropenia. Kaplan syndrome, the combination of rheumatoid arthritis, pneumoconiosis, and pulmonary nodules. Key fact: the distal interphalangeal dip joint is spared in rheumatoid arthritis, whereas it is commonly involved in osteoarthritis and psoriatic arthritis. Diagnosis of rheumatoid arthritis is based on a combination of clinical findings, laboratory tests, and imaging studies. According to diagnostic criteria, a score of 6 or more points is required for diagnosis. Points are assigned for the following: positive rheumatoid factor, RF, which are IgM antibodies against the Fc portion of IgG, or the presence of anti-cyclic citrullonated peptide, anti-CCP, antibodies, 1 point. Elevated erythrocyte sedimentation rate, ESR, or C-reactive protein, CRP, 1 point. Inflammatory arthritis involving 3 or more joints, up to 5 points. Symptom duration greater than 6 weeks, 1 point. It is also essential to exclude diseases with similar presentations, such as psoriatic arthritis, gout, pseudogout, and systemic lupus erythematosus. Laboratory tests usually show elevated ESR and CRP, reflecting systemic inflammation. Anemia of chronic disease is a common hematologic finding. Synovial fluid aspirate reveals turbid, low-viscosity fluid with an elevated white blood cell count between 2,000 and 50,000 cells per microliter, indicating inflammation. Imaging studies, though not required for diagnosis, can help assess disease progression. Early findings on X-ray include soft tissue swelling and juxtaarticular demineralization. As the disease advances, radiographs reveal symmetric joint space narrowing and erosions of the articular surfaces, reflecting irreversible joint damage. Treatment of rheumatoid arthritis centers on early and aggressive use of disease-modifying antiemetic drugs, DMARDs, to prevent joint destruction and disability. The initial drug of choice is methotrexate, a cornerstone of therapy. Other commonly used DMARDs include hydroxychloroquine and sulfasalazine. If patients fail to respond adequately to first-line therapy, second-line agents may be introduced, such as tumor necrosis factor, TNF, inhibitors, rituximab, an anti-CD20 monoclonal antibody, or leflunomide. Nonsteroidal anti-inflammatory drugs, NSAIDs, or glucocorticoids may be used for symptomatic relief during acute flares or while awaiting the therapeutic effects of DMARDs, bridging therapy. Key fact: hydroxychloroquine can cause irreversible retinal toxicity. Patients taking this medication for long durations, typically more than 5 years, must undergo regular ophthalmologic examinations to monitor for signs of toxicity, such as the characteristic bullseye appearance on retinal examination. Complications of rheumatoid arthritis are numerous and can be divided into articular and extraarticular manifestations. Articular manifestations include joint deformities, osteopenia, and secondary osteoarthritis. Extraarticular manifestations include anemia of chronic disease, rheumatoid nodules, scleritis, amyloidosis, cardiovascular disease, vasculitis, pulmonary fibrosis, Kaplan syndrome, carpal tunnel syndrome, Sjogren syndrome, and Feltes syndrome. Seronegative spondyloarthropathy. Ankylosing spondylitis is a chronic inflammatory disease of the spine and pelvis that leads to erosion and fusion of the sacroiliac joint. It is strongly associated with HLA, B27, and risk factors include male sex and family history. The typical onset is in the late teens and early 20s, presenting with fatigue, intermittent hip pain, and low back pain that worsens with inactivity and at night but improves with activity. As the disease progresses, there is decreased spine flexion, a positive Schober test, loss of lumbar lordosis, and increased hip pain and stiffness. Vertebral fracture may occur even after minimal trauma. Ankylosing spondylitis is associated with anterior uveitis, aortic insufficiency, psoriasis, inflammatory bowel disorder, and heart block. About 30% of cases are associated with enthesitis at tendon or ligament insertions, such as the Achilles tendon, and with dactylitis, also called sausage digits. Other seronegative spondyloarthropathies include reactive arthritis, psoriatic arthritis, and enteropathic spondylitis. Reactive arthritis is a disease of young adults characterized by arthritis, uveitis or conjunctivitis, and urethritis, usually following infection with Campylobacter, Shigella, Salmonella, Yersinia, Chlamydia, or ureaplasma. Psoriatic arthritis is an oligoarthritis that can involve the distal interphalangeal joints and is associated with psoriatic skin changes and sausage-shaped digits, known as dactylitis. X-rays show the classic pencil-in cup deformity, in which the middle phalanx tapers and appears to fit into the eroded distal phalanx. Enteropathic spondylitis is an ankylosing spondylitis-like disease characterized by sacroiliitis that is usually asymmetric and associated with inflammatory bowel disease. Keratoderma blennorrhagica, which causes skin lesions on the palms and soles, and circinate balanitis, which causes painless ulcerative lesions on the glans penis, are characteristic cutaneous features. The mnemonic for reactive arthritis is can't see, can't pee, can't climb a tree. Diagnosis of ankylosing spondylitis is made with X-rays showing erosion, ankylosis, fusion, or sclerosis of the sacroiliac joints, squaring of the lumbar vertebrae, and the development of vertical syndesmophytes and bamboo spine appearance. Laboratory findings include positive HLA-B27 in 85 to 95% of cases, elevated ESR or CRP in 85% of cases, and negative rheumatoid factor and antinuclear antibody. Treatment includes nonsteroidal anti-inflammatory drugs as the best initial therapy, along with exercise to improve posture and breathing. In refractory cases, tumor necrosis factor inhibitors, interleukin-17 inhibitors, or sulfasalazine are used. Polymyositis and dermatomyositis are progressive immune-mediated myopathies characterized by striated muscle inflammation manifesting as symmetric proximal muscle weakness. Polymyositis presents with muscle weakness, while dermatomyositis is differentiated by cutaneous involvement. They most often affect patients between 50 to 70 years of age, with a male-to-female ratio of 1 to 2. Black individuals are affected more often than white individuals. Both conditions present with symmetric, progressive proximal muscle weakness and pain, causing difficulty getting up from a seat or climbing stairs, and in advanced disease, difficulty breathing or swallowing. In polymyositis, muscle weakness occurs without rash, whereas dermatomyositis is associated with characteristic skin findings, such as a heliotrope rash, which is a violaceous periorbital rash. A shawl sign, which is a rash involving the shoulders, upper chest, and back. And Gottram papules, which are papular rashes with scales on the dorsi of the hands over bony prominences. On biopsy, polymyositis shows endomysial inflammatory infiltrates surrounding muscle fibers, whereas dermatomyositis shows perifascicular inflammatory infiltrates. 10% of polymyositis and dermatomyositis cases are associated with interstitial lung disease. Esophageal involvement can present as dysphagia, and cardiac involvement can present as myocarditis and cardiac conduction deficits. Both polymyositis and dermatomyositis can be associated with underlying malignancy, especially lung, breast, and ovarian carcinoma, with dermatomyositis showing a higher rate of malignancy compared to polymyositis. Diagnosis is based on characteristic clinical presentation and laboratory values. The best initial test is elevated serum creatine kinase and the presence of anti-Jo-1 antibodies, common antibodies, and their autoimmune disease associations. Antinuclear antibody, or ANA, is associated with systemic lupus erythematosus. Anti-CCP antibody is associated with rheumatoid arthritis. Anticentromere antibody is associated with CREST syndrome. Anti-double-stranded DNA or anti-dsDNA antibody is associated with systemic lupus erythematosus. Antihistone antibody is associated with drug-induced lupus erythematosus. Anti-Jo-1 antibody is associated with polymyositis and dermatomyositis. Anti-Rho and anti-La antibodies are associated with Sjogren's syndrome. Anti-SCL70, also known as antitopoisomerase I antibody, is associated with systemic sclerosis. Anti-SM, or anti-Smith antibody, is associated with systemic lupus erythematosus. Anti-smooth muscle antibody is associated with autoimmune hepatitis. CNCA, or cytoplasmic antineutrophil cytoplasmic antibody, is associated with vasculitis, especially granulomatosis with polyangiitis, formerly known as Wegener syndrome. PNCA, or paranuclear antineutrophil cytoplasmic antibody, is associated with vasculitis, particularly microscopic polyangiitis. Rheumatoid factor, or RF, is associated with rheumatoid arthritis. U1-RNP antibody is associated with mixed connective tissue disease. The most accurate test is muscle biopsy to differentiate between polymyositis and dermatomyositis in atypical presentations. Aldolase, lactate dehydrogenase, aspartate aminotransferase, and alanine aminotransferase are also muscle enzymes. In patients with unexplained elevation of AST and ALT, not due to alcohol abuse or liver disease, and especially if AST is greater than ALT, creatine kinase should be checked to evaluate for myopathy. Treatment consists of high-dose corticosteroids, such as prednisone, with tapering after 4 to 6 weeks to a maintenance dose. Azathioprine and methotrexate are used in steroid-resistant or intolerant cases. Temporomandibular joint disorders develop due to multiple contributing factors, including joint trauma, such as bruxism, and a history of psychiatric illness like depression or anxiety. Patients typically present with unilateral morning headaches accompanied by waxing and waning facial pain that worsens with jaw movement. The pain may also be associated with tinnitus and can radiate to the ear, the periorbital region, and down the mandible. On physical examination, there may be tenderness of the muscles of mastication, visible tooth, where from bruxism, and jaw movement may produce clicking or even locking that restricts the ability to open the mouth fully. The diagnosis of temporomandibular joint disorders is primarily clinical, based on the patient's history and physical examination findings. Treatment focuses on patient education and self-care, which includes avoidance of triggers and adherence to a soft diet. Pharmacologic therapy may involve NSAIDs and corticosteroid injections, while dental splints are recommended if bruxism is suspected. Myofascial pain syndrome shares certain features with fibromyalgia, but is distinct in that it is a regional pain disorder characterized by the presence of trigger points within the fascia and muscles. Patients describe a deep, aching pain often accompanied by a burning sensation and restricted active motion in the affected area. On physical examination, indurated regions known as trigger points can be palpated, and pressing these points reproduces pain in another location, referred to as the target zone. Myofascial pain syndrome differs from fibromyalgia in that fibromyalgia lacks indurated trigger points, and the tender points in fibromyalgia are located within tissues other than muscles. Treatment of myofascial pain syndrome is multidisciplinary and includes patient education, sleep hygiene, low-impact exercise, physical therapy, non-narcotic pain medications, antidepressants, gabapentin, and muscle relaxants. Systemic sclerosis, also called scleroderma, is a chronic inflammatory condition that results in progressive tissue fibrosis caused by excessive deposition of type 1 and type 3 collagen. It most commonly presents as CREST syndrome, which is the limited form seen in about 80% of cases, though a diffuse form occurs in approximately 20% of patients, involving widespread skin and multi-organ involvement. Risk factors include female sex and age between 35 and 50 years. The mnemonic for CREST syndrome stands for calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. On examination, patients may show symmetric thickening of the skin on the face and distal extremities. In a limited cutaneous form, involvement is typically confined to the head, neck, and distal upper extremities, which are usually the earliest affected areas. The diffuse cutaneous form involves the torso, abdomen, and proximal upper extremities or shoulders and may lead to gastrointestinal dysmotility, pulmonary fibrosis, cor pulmonale, acute renal failure known as scleroderma renal crisis, Raynaud phenomenon, and malignant hypertension. Scleroderma renal crisis presents with the abrupt onset of severe hypertension and acute renal failure, carrying a high mortality rate if not recognized and treated early. Diagnosis of systemic sclerosis and its subtypes is based on the constellation of symptoms and laboratory findings. Rheumatoid factor and antinuclear antibodies may be positive in many cases, with approximately 95% of patients showing positive ANA. Anti-scleroderma antibody, also known as anti-CL70 or antidopacinorase, is highly specific, with over 99% specificity but only about 20% to 45% sensitivity, and is associated with diffuse disease and a poor prognosis. Rheumatoid factor may also be positive. Anticentromer antibodies are specific for CREST syndrome. In severe disease, microangiopathic hemolytic anemia with schistocytes may be seen. A key diagnostic fact is that the presence of anti-RNA polymerase III antibody in scleroderma increases the risk of renal crisis. Treatment of systemic sclerosis is organ-based and focuses on frequent monitoring for progressive organ damage and providing symptomatic support as needed. Corticosteroids may be used for acute flares, but carry a risk of precipitating renal crisis. Methotrexate may be used in limited scleroderma. Calcium channel blockers of the dihydropyridine class, such as amlodipine, are used for the management of Raynaud phenomenon, while angiotensin-converting enzyme inhibitors are the treatment of choice for scleroderma renal crisis. Mortality in systemic sclerosis is most commonly due to complications such as interstitial lung disease or pulmonary fibrosis, pulmonary hypertension, and secondary renal or cardiac involvement. Systemic lupus erythematosus is a chronic multi-system autoimmune disorder caused by antibody-mediated cellular attack and deposition of antigen-antibody complexes in various organs, leading to a wide range of clinical manifestations and presentations. Black women are at the highest risk, and the disease most commonly affects women of childbearing age. Patients typically present with nonspecific symptoms such as fever, anorexia, weight loss, and symmetric joint pain. Because of its clinical heterogeneity and nonspecific features, SLE often poses a diagnostic challenge and is considered a diagnosis of exclusion. The mnemonic dopamine rash helps summarize the diagnostic criteria for SLE. Discoid rash, oral ulcers, photosensitivity, arthritis, non-deforming. Malar rash, immunologic criteria, anti-dsDNA, anti-SM proteins, anti-phospholipids. Neurologic symptoms, lupus cerebritis, seizures, elevated ESR, renal disease, ANA positivity, serositis, pleural or pericardial effusion, and hematologic abnormalities. The malar rash of SLE is typically red to purple with a continuous plaque extending across the bridge of the nose and both cheeks, characteristically sparing the nasolabial folds. Diagnosis of SLE is based on the American College of Rheumatology, ACR, criteria summarized by the mnemonic above. The presence of 4 or more of these criteria strongly supports the diagnosis, with about 96% sensitivity and specificity. A positive ANA is highly sensitive and is present in 95% to 99% of cases. If ANA is positive, testing for anti-dsDNA and anti-SM antibodies is recommended, as these are highly specific but less sensitive markers. In drug-induced lupus, antihistone antibodies are seen in nearly 100% of cases, although they are nonspecific. Common offending medications include hydralazine, procainamide, and isoniazid. Neonatal lupus results from the transplacental passage of maternal anti-Rho antibodies, which may lead to congenital heart block in the neonate. Other findings may include low complement levels during acute disease flares and the presence of antiphospholipid antibodies, including anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant, all of which contribute to a hypercoagulable state and may cause thromboembolism and recurrent spontaneous abortions. Additional associated findings can include Raynaud phenomenon, anemia, leukopenia, thrombocytopenia, proteinuria, and the presence of urinary casts. A key fact to remember is that the lupus anticoagulant, seen in 5% to 10% of SLE cases, can bind IgM or IgG to proteins in a clinical assay, causing prolongation of partial thromboplastin time, PTT. Another important feature is Liebman-Sachs endocarditis, which presents with non-infectious vegetations on the mitral valve and is associated with SLE and antiphospholipid syndrome, remembered by the correspondence LS endocarditis with SLE. Treatment depends on disease severity. NSAIDs are used for mild joint symptoms, while corticosteroids are indicated for acute exacerbations, though long-term use carries the risk of Cushing's syndrome and avascular necrosis. For progressive or refractory disease, medications such as corticosteroids, hydroxychloroquine, cyclophosphamide, mycophenolate, and azathioprine are used. Hydroxychloroquine is preferred for isolated skin and joint involvement, while cyclophosphamide or mycophenolate is used for severe lupus nephritis, with renal biopsy indicated in patients showing nephritic symptoms. Major complications of SLE that contribute to morbidity and mortality include renal failure, cardiovascular disease, and infections. Key facts include that SLE can cause a false positive venereal disease research laboratory, VDRL, or rapid plasma reagent, RPR, test, and that both SLE and rheumatoid arthritis can affect the MCP and PIP joints. However, in SLE, the joint disease is non-deforming and non-erosive, a pattern known as Charcot arthropathy. Serum sickness, like reaction, is a self-limited hypersensitivity response that presents with fever, urticarial rash, arthralgia, lymphadenopathy, and proteinuria within 1 to 2 weeks of exposure to a beta-lactam antibiotic, such as penicillin or amoxicillin, or a sulfa drug, such as trimethoprim sulfamethoxazole. The symptoms typically resolve once the offending drug is discontinued. Giant cell arteritis, formerly known as temporal arteritis, is the most common of the systemic vasculitides. It results from subacute granulomatous inflammation of large vessels, including the aorta, external carotid artery, particularly its temporal branch, and the vertebral arteries. Risk factors include age over 50 years, female sex, and a history of polymyalgia rheumatica, which affects nearly half of patients. Vasculitis is classified by vessel size. Large vessel vasculitis includes giant cell arteritis and Takayasu arteritis, both granulomatous arteritis involving the aorta and major arteries. Medium vessel vasculitis includes polyarteritis nodosa and Kawasaki disease, both necrotizing arteritis affecting medium-sized arteries. Small vessel vasculitis includes posse-immune types often associated with ANCA, such as microscopic polyangiitis, granulomatosis with polyangiitis, Wegener granulomatosis, and eosinophilic granulomatosis with polyangiitis, Church-Strauss syndrome. Immune complex mediated small vessel vasculitis includes systemic lupus erythematosus, mixed cryoglobulinemia, IgA vasculitis, Henoch-Schönlein purpura, and anti-GBM vasculitis, Goodpasture disease. Patients typically present with new-onset headaches that may be unilateral or bilateral, scalp pain, temporal tenderness, and jaw claudication. Other symptoms include fever, weight loss, myalgias or arthralgias, especially in the shoulders and hips, transient or permanent monocular vision loss, and occasionally aortic aneurysm formation. The best initial diagnostic test is an erythrocyte sedimentation rate greater than 50 millimeters per hour, though the result may vary with age. The most accurate diagnostic test is a temporal artery biopsy, which shows thrombosis, necrosis of the media, and an inflammatory infiltrate composed of lymphocytes, plasma cells, and multinucleated giant cells. Treatment must begin immediately upon suspicion of the disease to prevent irreversible ocular complications. The best initial therapy is high-dose prednisone, which should be administered promptly even before biopsy confirmation. If there is evidence of visual involvement or risk to the remaining eye, pulse dose steroids should be given. Temporal artery biopsy should still be performed to confirm the diagnosis, but treatment should never be delayed for the procedure. A follow-up ophthalmologic examination is also recommended. The most feared complication of giant cell arteritis is blindness, caused by anterior ischemic optic neuropathy due to occlusion of the posterior ciliary artery, which is a branch of the ophthalmic artery arising from the internal carotid artery. Less commonly, occlusion of the central retinal artery may occur, sometimes presenting initially as transient vision loss. Clinical case. A 55-year-old woman presents to the clinic with a chief complaint of blindness. She states that she experienced a temporary loss of vision in her left eye. She has also been experiencing new headaches and soreness in her jaw. Her vision exam is unremarkable. What diagnostic exam should be ordered? Monocular amaurosis fugax is associated with giant cell, temporal, arteritis, and may progress to complete vision loss. A temporal artery biopsy should be obtained. Takayasu arteritis is a large vessel autoimmune vasculitis affecting the aorta and its primary branches, commonly seen in Asian females under 40 years of age. Diagnosis is based on clinical presentation and imaging. Classic symptoms include aortic claudication, differential blood pressure in both upper extremities, and absence of palpable pulses, known as pulseless disease. ESR and CRP are often elevated. Imaging with magnetic resonance angiography or computed tomography angiography shows narrowing of the aorta or its primary branches. Treatment is with oral high-dose steroids. BEHÇET syndrome is an autoimmune vasculitis common in males of Turkish or Middle Eastern descent, characterized by recurrent painful oral and genital ulcers and uveitis. Thrombosis is a common cause of morbidity. Colchicine is used to prevent recurrence. Topical steroids treat oral and genital ulcers, and ophthalmic steroids treat ocular involvement. Fibromyalgia is a chronic musculoskeletal pain disorder primarily affecting young females, characterized by soft tissue and axial skeletal pain without joint inflammation. Inflammation is absent, and it may be difficult to distinguish from myofascial pain when fewer than 11 painful areas are present. Characteristic differences between fibromyalgia and polymyalgia rheumatica are as follows. Fibromyalgia typically affects females between 30 to 50 years of age, whereas polymyalgia rheumatica affects females over 50 years of age. In fibromyalgia, pain is located in various parts of the body, while in polymyalgia rheumatica is localized to the shoulder and pelvic girdle. ESR is normal in fibromyalgia, but markedly elevated, often greater than 100 millimeters per hour, in polymyalgia rheumatica. Creatine kinase levels remain normal in both conditions, and muscle biopsy findings are also normal in both. Classic findings in fibromyalgia include anxiety, stress, and point tenderness, while polymyalgia rheumatica is associated with temporal arteritis and shows a strong response to steroids. Treatment for fibromyalgia involves antidepressants, NSAIDs, and rest, whereas polymyalgia rheumatica is treated with low-dose prednisone. Fibromyalgia is most common in females between 30 and 50 years of age and is associated with depression, anxiety, sleep disorders, irritable bowel syndrome, and cognitive disturbances known as fibrofog. Diagnosis is made when there are multiple painful areas over all 4 body quadrants and the axial skeleton for more than 3 months, with no other identifiable pathology. Treatment begins with a non-pharmacologic approach that includes patient education about the disease, good sleep hygiene, low-impact exercise, psychotherapy, and physical therapy, such as stretching, heat therapy, and hydrotherapy. If symptoms persist, pharmacologic options include antidepressants, such as tricyclics or serotonin-norepinephrine reuptake inhibitors, gabapentin, pregabalin, or muscle relaxants. Narcotics should be avoided. Polymyalgia rheumatica is an inflammatory rheumatic condition characterized by aching and stiffness in the shoulders, hips, and neck, commonly associated with temporal arteritis. It primarily affects females over 50 years of age. Patients typically present with pain and stiffness in the shoulder and pelvic girdle muscles, having difficulty rising from a chair or lifting their arms above the head. Other symptoms may include fever, malaise, and weight loss, though muscle weakness is generally absent on examination. Diagnosis is supported by elevated ESR and/or CRP with a normal creatine kinase level. Treatment consists of low-dose prednisone, typically 10 to 20 milligrams per day. Upper extremity. Adhesive capsulitis, also known as frozen shoulder, is a pathology of the glenohumeral joint in which the shoulder loses its normal range of motion. This condition may be idiopathic or secondary to several predisposing conditions, such as shoulder injury, rotator cuff tear, humeral fracture, surgery, subacromial bursitis, diabetes mellitus, hypothyroidism, Dupuytren contracture, or paralytic stroke. It commonly presents in middle-aged and older individuals with a gradual onset of poorly localized, nagging shoulder pain that is worse at night. The pain is accompanied by significant reduction in both active and passive shoulder range of motion, and patients may have difficulty reaching overhead, scratching their back, or putting on a coat. Diagnosis is clinical, based on reduced active and passive mobility in multiple planes. Imaging is not usually required unless ruling out other shoulder pathologies. Treatment involves range of motion exercises and physical therapy. If symptoms persist, corticosteroid injections, arthroscopic distension, surgical release, and NSAIDs may be used. Rotator cuff injuries are a common cause of shoulder pain in older adults and typically result from impingement, glenohumeral osteoarthritis, or acute trauma. The supraspinatus is most commonly torn, though the subscapularis, infraspinatus, or teres minor may also be affected. Sports requiring overhand motion, such as baseball or swimming, can cause tears in young adults, and impingement or tendinopathy often precedes a full rotator cuff tear. Tendinitis is a slight misnomer since classic inflammation is minimal in overused tendinopathy. Tendinosis is the more accurate term for chronic tendon injury without cellular inflammation. Rotator cuff tears can be acute or chronic, with chronic tears causing gradual pain in older adults. Impingement syndrome occurs when soft tissue structures are compressed, leading to a more insidious onset of pain. In impingement, range of motion remains normal, but abduction and external rotation are painful. The Near-Sign and Hawkins test are often positive, indicating impingement. Physical examination maneuvers for shoulder pathology include the Near test, Hawkins test, and drop arm test. In the Near test, pain upon passively raising an internally rotated arm with the thumb pointing toward the floor halfway between forward elevation and abduction indicates a positive result for impingement. In the Hawkins test, pain upon internally rotating an arm that is flexed 90 degrees at both the shoulder and elbow also indicates impingement. The drop arm test is positive if the patient drops their arm due to pain or weakness while slowly lowering it from 90 degrees of abduction, suggesting a rotator cuff tear. Rotator cuff tears present with painful and weak abduction and external rotation, and a positive drop arm sign if the supraspinatus is torn. Risk factors include trauma, shoulder dislocation, and age over 40 years. Diagnosis of impingement is made with X-ray, while for suspected tears, particularly with preceding trauma, weakness, or a positive drop arm sign, MRI is the best next test. Treatment begins with conservative management, such as physical therapy, with surgical repair considered if symptoms persist or fail to improve. Compartment syndrome is a condition characterized by increased pressure within a confined space that compromises nerve, muscle, and soft tissue perfusion. It occurs most commonly in the anterior compartment of the lower leg and in the forearm, usually secondary to trauma such as fractures or muscle injury. Non-traumatic causes include thrombosis leading to ischemia-reperfusion injury and prolonged limb compression, often seen in patients who overuse alcohol or drugs. Symptoms develop acutely over several hours. The patient presents with pain out of proportion to physical findings, pain with passive motion of fingers and toes, and the 6Ps, paresthesias, pallor, poikilothermia, pulselessness, and paralysis. Paralysis and pulselessness are late signs of compartment syndrome. Volkmann contracture of the wrist and fingers is caused by compartment syndrome, often associated with supracondylar humerus fractures that may injure the brachial artery and radial nerve, leading to ischemia and fibrosis of dead muscle. The timeline of symptoms begins with early nerve dysfunction showing pain out of proportion and paresthesia, followed by late vascular insufficiency presenting as pallor, poikilothermia, paralysis, and pulselessness. Diagnosis is based on history, serial examinations, and elevated compartment pressure greater than 30 millimeters of mercury. The delta pressure, calculated as diastolic pressure minus compartment pressure, confirms the diagnosis when it is less than or equal to 30 millimeters of mercury. Treatment is an emergent fasciotomy to relieve pressure and restore tissue perfusion. Time to fasciotomy is critical. If performed within 6 hours from symptom onset, limb recovery approaches nearly 100%. Delay beyond 6 hours increases the risk of residual nerve dysfunction, muscle necrosis, and possible amputation. Open fractures are orthopedic emergencies, while closed tibia and forearm fractures have a higher risk of developing compartment syndrome. Patients should be taken to the operating room within 8 to 24 hours for irrigation, debridement, and fracture repair. Infection risk must be reduced with antibiotics and tetanus prophylaxis. Rhabdomyolysis is caused by muscle necrosis and the subsequent release of intracellular byproducts into the systemic circulation. The hallmark finding is an elevated creatine kinase (CK) level. Common etiologies include direct muscle injury, such as trauma, compression, or compartment syndrome, extreme physical exertion as seen in power lifters and marathon runners, exposure to toxins, and syndromes like malignant hyperthermia. Clinically, patients often present with muscle pain, tenderness, and weakness, though some may be asymptomatic. A classic feature is dark or bloody urine caused by myoglobinuria. Diagnosis is confirmed by a markedly elevated serum CK level, typically greater than 1500 UL or 5 times the upper limit of normal. Urinalysis is positive for myoglobin but shows minimal red blood cells. Laboratory findings may also include hyperkalemia and hyperphosphatemia, with possible development of acute kidney injury. Treatment involves aggressive intravenous fluid resuscitation to prevent renal damage and correction of electrolyte abnormalities. Management of the underlying cause, such as relieving compartment syndrome or treating malignant hyperthermia, is essential. A major complication of rhabdomyolysis is acute kidney injury, which occurs in 15% to 50% of cases due to volume depletion and direct nephron toxicity from myoglobin. Clinical case. A 37-year-old man is seen after a motorcycle accident. He complains of intense leg pain, tingling in his foot, and inability to move his toes. A physical examination reveals pain with passive motion of his toes and palpable dorsalis pedis pulses. An X-ray film confirms a tibial fracture. What is the best treatment? The best treatment is immediate fasciotomy for compartment syndrome within 6 hours to prevent muscle necrosis, followed by fracture stabilization. Remember that non-palpable pulses are a late finding. Carpal tunnel syndrome is caused by entrapment of the median nerve at the wrist due to a decrease in the size or space of the carpal tunnel, leading to paresthesia, pain, and sometimes paralysis. It may result from overuse of wrist flexors and is associated with pregnancy, diabetes mellitus, hypothyroidism, acromegaly, rheumatoid arthritis, and amyloidosis. Pronator syndrome is a similar condition caused by compression of the median nerve at the elbow, presenting with paresthesia in the same distribution but with fewer nighttime symptoms and a positive Tinel sign at the proximal anterior forearm, often linked to hypertrophic forearm muscles. Sensory loss in carpal tunnel syndrome is a late finding that spares the thenar eminence because that area is supplied by the palmar sensory cutaneous nerve, which passes over the carpal tunnel rather than through it. Patients typically present with difficulty performing activities such as typing, turning doorknobs, opening bottles, or driving. They experience aching pain over the thenar area and proximal forearm, along with paresthesia or numbness in the median nerve distribution involving the first 3.5 digits. Symptoms usually worsen at night and may awaken the patient from sleep. On examination, there may be thenar eminence atrophy in long-standing cases. The Phelan maneuver, Tinel test, and Durkin test, carpal compression test, may all be positive. Diagnosis is primarily clinical, supported by electrodiagnostic studies such as nerve conduction tests and electromyography, if needed. The best initial treatment is wrist splinting in a neutral position, especially at night. Medical management includes corticosteroid injections into the carpal canal and NSAIDs for symptom relief. The most definitive treatment is surgical decompression of the carpal tunnel, especially in patients with persistent symptoms, fixed sensory loss, or thenar weakness despite conservative therapy. If left untreated, complications include permanent loss of sensation, hand strength, and fine motor skills. A ganglion cyst is a fluid-filled cyst that arises from tendon sheaths, ligaments, or joint connective tissue, most commonly found on the dorsum of the wrist. It typically presents as a slowly growing, rubbery, round, and firm mass over a joint that causes wrist pain and is relatively immobile due to its connection with joint tissue. Diagnosis is made through transillumination, which shows a fluid-filled structure, and ultrasound can help differentiate a simple cyst from a multiloculated cyst or solid mass, such as a lipoma or tumor. Treatment involves observation, as up to 50% of cases regress spontaneously. Surgical excision is indicated for cysts that persist, cause symptoms, or have concerning features, with a recurrence rate of about 10%. Dupuytren contracture is caused by a disorder of fibroblastic proliferation and collagen deposition in the palmar fascia of the hand, leading to progressive fibrosis. It commonly appears after the 5th decade of life, most often in white males. It begins as a painless nodule in the palm that gradually thickens and develops into fibrotic cords, eventually causing a permanent flexion contracture of the digits with an inability to extend the fingers. The ulnar side of the hand is most often affected, especially the MCP and PIP joints of the 4th and 5th digits. Diagnosis is made clinically by the presence of palmar nodules or cords and the inability to fully extend the affected fingers. Treatment involves surgical correction with fasciotomy or fasciectomy, while percutaneous needle aponeurotomy offers a less invasive but less effective option. Recurrence is common even after surgery. Avascular necrosis, AVN, also known as osteonecrosis or ischemic necrosis, result from disruption of the bone's blood supply, causing bone death. It frequently involves the scaphoid bone after a fall onto an outstretched hand or the femoral head due to conditions such as sickle cell disease, chronic glucocorticoid or bisphosphonate use, or femoral fracture. Scaphoid necrosis presents with pain in the anatomic snuff box after a fall, while femoral head necrosis presents with dull or sharp hip pain. In children, AVN may occur as Legg-Calvé disease or slip capital femoral epiphysis. Diagnosis is made with X-ray, though early findings may be negative. MRI is the gold standard when suspicion is high. In scaphoid fractures, delayed imaging after 2 to 6 weeks is necessary to detect necrosis or displacement. Treatment involves wrist splinting for non-displaced scaphoid injuries and surgical referral for displaced fractures or neurovascular compromise. Femoral head AVN typically requires total hip replacement. Raynaud phenomenon is an abnormal vasoconstriction of peripheral arteries in response to cold, leading to a characteristic progression of color changes in the digits. During ischemia, vasospasm causes occlusion and pallor, producing pale white digits. This is followed by cyanosis as capillaries dilate and fill with deoxygenated blood, giving a blue color, and finally rubor occurs as vasospasm resolves and reperfusion restores blood flow, producing red digits. It may occur as a primary condition or be associated with autoimmune diseases. Testing for ANA and RF helps in diagnosis. First-line treatment involves avoiding cold and other triggers, and pharmacologic management includes calcium channel blockers such as amlodipine or nifedipine. Key fact: Raynaud phenomenon may be triggered by cold temperatures and stress. Keeping the body's core warm is essential. It can be treated with calcium channel blockers, CCBs, such as nifedipine or amlodipine. Hand infections and bite wounds require urgent evaluation and management. Both human and animal bites carry a high risk of infection and should be treated empirically. A fight bite, caused by striking another person's mouth, is particularly dangerous due to oral bacteria and the potential for septic arthritis. Patients present with pain, erythema, and swelling that may limit movement. Alarm signs include crepitus, suggesting necrotizing infection, and skin discoloration, indicating necrosis or ischemia. Laboratory evaluation may reveal leukocytosis, and wound cultures guide antibiotic therapy. Plain radiographs should be obtained to rule out fracture, foreign bodies, osteomyelitis, or subcutaneous gas. Broad-spectrum antibiotics are started empirically. Dog and cat bites are commonly caused by Pastorella, Staphylococcus, and Streptococcus, while human bites often involve Eikenella and group A Streptococcus. Severe or necrotizing infections require urgent surgical debridement and source control, and septic arthritis demands joint aspiration and surgical management. Without prompt treatment, infection can lead to loss of digits, limb, or permanent deformity. Lower extremity. Osteochondritis dissecans, OCD, often presents in adolescent children in which a part of the subchondral bone detaches from the underlying bone. OCD has a propensity to affect boys. It results from repeated trauma in highly active children. The most common joints involved include the knee, elbow, and ankle, often with a history of ankle inversion. Patients complain of dull, poorly localized joint pain that worsens with activity. Accompanying swelling, stiffness, crepitus, and tenderness may be present. In advanced stages of the disease, patients can have an antalgic gait, rotating the affected limb laterally to reduce pain from weight-bearing, and may complain of a catching and locking sensation. Diagnosis is based on visualization of a subchondral bone fragment on plain radiograph. In case of high suspicion and normal radiograph, an MRI can be obtained. Treatment includes rest, physical therapy, and surgery in severe disease. Bursitis is inflammation of the joint bursa by repetitive use, trauma, infection, systemic inflammatory disease such as autoimmune disease, or crystalline disorders such as gout. Common sites of bursitis include subacromial, olecranon, trochanteric, popliteal fossa, Baker's cyst, prepatellar, housemaid's knee, and infrapatellar bursae. It presents as pain, tenderness, swelling, and reduction in active range of motion, but with limited impact on passive range of motion. Presence of abrasion, overlying cellulitis, or puncture wound or history of buccal injection with accompanying fever and chills suggests a septic etiology, often due to Staphylococcus aureus. Diagnosis is based on history and physical examination. In case of suspected septic or crystalline etiology, aspiration should be performed. Treatment includes activity modification and NSAIDs for non-septic cases. In case of septic etiology, systemic antibiotics are required, with surgical debridement in selected cases. PS anserinous pain syndrome, also called anserine bursitis, is common in young adults active in sports, overweight middle-aged females, and older adults with osteoarthritis. It presents with localized pain at the anteromedial tibia at the insertion of the PS anserinus, just below the joint line, that is aggravated by overuse, obesity, knee osteoarthritis, and pressure from the opposite knee while lying on the side. The pain typically develops over weeks and worsens overnight. The valgus stress test will not aggravate the pain, and X-rays will be normal. Treatment includes NSAIDs and strengthening of the quadriceps muscles. Clinical case. A 23-year-old man presents to the emergency department with a swollen and erythematous right hand following an altercation at a bar a few days ago. The dorsum of the hand shows abrasions, and X-ray films reveal a fracture of the fifth metacarpal. What is the next step in management? If skin is broken in a boxer's fracture, assume infection by human oral pathogens and treat with surgical irrigation, debridement, and IV antibiotics to cover Eikenella. Patellofemoral pain syndrome is anterior knee pain caused by overuse. It is common in females, runners, cyclists, and athletes. Pain can be reproduced with knee extension or using stairs. Treatment includes activity modification, often rest, and NSAIDs. Patients present with localized tenderness, decreased range of motion, edema, and erythema, with a possible history of trauma or inflammatory disease. Pain is reproducible with squatting and worsens with ascending or descending stairs. Diagnosis can overlap with patellar tendinitis, which causes localized pain directly beneath the patella. Infection of the superficial bursae occurs after trauma to the skin, while infection of deep bursae is often iatrogenic following injections or aspirations. Diagnosis is mainly clinical based on symptoms and physical exam findings. Needle aspiration is indicated if septic bursitis is suspected and no labs or imaging are needed. The best initial treatment includes rest, heat and ice, elevation, and NSAIDs, with physical therapy to strengthen the quadriceps. An intrabursal corticosteroid injection can be considered, but is contraindicated if septic bursitis is suspected. Septic bursitis should be treated with 7 to 10 days of antibiotics. In a child with gout and inexplicable injuries, consider Lesch-Nyhan syndrome caused by hypoxanthine guanine phosphorybosyltransferase deficiency. Morton neuroma is a neuropathic degeneration of nerves, most commonly between the third and fourth toes, causing numbness, pain, and paresthesia. It is often associated with a clicking sensation when palpating the joint space. Morton neuroma occurs in runners, and symptoms worsen when metatarsals are squeezed together, such as when wearing high-heeled shoes or walking on hard surfaces. Treatment includes padded shoe inserts to decrease pressure on metatarsal heads or surgical removal. Gout is a condition characterized by recurrent attacks of acute monoarticular arthritis resulting from intraarticular deposition of monosodium urate crystals caused by disorders of urate metabolism, either increased production or decreased excretion. Risk factors include male sex, obesity, postmenopausal status in women, and binge drinking. Gout crystals appear yellow when parallel to the condenser. It presents with sudden onset of excruciating joint pain associated with erythema, warmth, swelling, and decreased range of motion. Fever and mild leukocytosis can also be present. 80% of cases are monoarticular, and gout most commonly affects the first metatarsophalangeal joint, known as podagra, as well as the midfoot, knees, ankles, and wrists, while the hips and shoulders are generally spared. Tophi, which are urate crystal deposits in soft tissue, are seen with chronic disease and are associated with tissue destruction. Tophi are virtually pathognomonic for gout and appear as painless, non-tender nodules that can ulcerate and discharge a chalky white substance. Uric acid kidney stones can also occur in chronic disease. Diagnosis requires joint synovial fluid aspiration because septic arthritis can present similarly. The aspirate shows needle-shaped, negatively birefringent crystals. Gout versus pseudogout. Gout, caused by uric acid crystal deposition, commonly occurs in males with risk factors such as binge drinking, recent surgery, or hyperuricemia. It typically affects the first big toe, known as podagra, as well as other joints. The crystals in gout are needle-shaped and show negative birefringence under polarized light microscopy. Pseudogout, also called calcium pyrophosphate deposition disease, or CPPD, is associated with conditions like hemochromatosis and hyperparathyroidism. It most commonly affects the wrists and knees, and its crystals are rhomboid-shaped with positive birefringence. Serum uric acid levels are usually elevated, typically greater than or equal to 7.5 milligrams DL, but may be normal or decreased during an acute attack. ESR and CRP are usually elevated, and joint fluid aspiration is required to clarify the diagnosis. X-rays may reveal punched-out erosions with overhanging cortical bone, known as rat bite erosions, which are seen in advanced gout. Causes of hyperuricemia include increased cell turnover as seen in hemolysis, blast crisis, tumor lysis syndrome, myelodysplasia, and psoriasis. Medications such as cyclosporin, diuretics, and low-dose salicylates. Physiologic states such as dehydration, starvation, and obesity. Diseases such as diabetes insipidus, HGPRT deficiency, and glucose 6-phosphatase deficiency. Dietary factors including increased consumption of red meat and alcohol, diuretic use, lead poisoning, Lesch-Nyhan syndrome, and salicylates, low dose. Clinical case. A 49-year-old man presents with a painful, swollen big toe after a night of heavy drinking. How does alcohol affect uric acid metabolism? Alcohol is a source of purines, which are metabolized into uric acid, increasing serum concentrations and predisposing patients to gout flares. Treatment of acute gout attacks includes high-dose NSAIDs, such as indomethacin, as first-line therapy. NSAIDs should be avoided in patients with congestive heart failure, chronic kidney disease, peptic ulcer disease, or those taking anticoagulants. Colchicine may also be used, and it is most effective when administered within 24 hours of attack onset. Steroids are indicated when NSAIDs are ineffective or contraindicated, such as in renal insufficiency. Intra-articular steroid injections are preferred if only one or two joints are affected, while systemic steroids are used for more widespread involvement. Maintenance therapy is indicated for patients who experience 2 or more attacks annually, have tophi, or have structural joint damage. Maintenance medications include xanthine oxidase inhibitors such as allopurinol and febuxostat, which may increase the incidence of urate nephropathy, and uricosuric agents such as probenecid, which are contraindicated in patients with tophi, nephrolithiasis, or chronic kidney disease. Weight loss and avoidance of triggers, such as binge drinking and red meat consumption, can prevent recurrent attacks. Allopurinol and febuxostat are both xanthine oxidase inhibitors. They decrease the metabolism of azathioprine and 6-mercaptopurine, leading to profound toxicities, and therefore should be avoided in patients taking azathioprine or mercaptopurine. Pseudogout is an acute synovitis that presents similarly to gout attacks, with flares often occurring in the setting of recent surgery or or medical illness. It is a disease that primarily affects older adults and is characterized by the deposition of calcium pyrophosphate crystals into the joint space. Peripheral joints are most commonly involved, with the knee joint being the classic site of presentation. Risk factors include hemochromatosis, hypothyroidism, and hypercalcemia. Colchicine inhibits neutrophil chemotaxis and is most effective in pseudogout when used within 24 hours of flare onset. However, it can cause diarrhea, neuromyopathy, and bone marrow suppression, leading to neutropenia. The history and physical examination findings are the same as those seen in gout. Diagnosis is based on joint aspiration showing rhomboid-shaped birefringent crystals. While imaging classically reveals chondrocalcinosis, which appears as punctate and linear lesions corresponding to the deposition of calcium-containing crystals in the articular cartilage. Treatment includes intra-articular corticosteroid injections, NSAIDs, and colchicine. Trunk. Low back pain, also known as LBP, is the second leading symptom-related cause for office visits in the United States. Although it is often self-limited, it can sometimes indicate more serious underlying conditions such as infection, malignancy, or an abdominal aortic aneurysm, AAA. Routine imaging is generally not necessary for most patients with acute low back pain unless red flag symptoms are present. Most cases of low back pain are mechanical in nature, meaning they are due to strain, degenerative changes, or poor posture rather than systemic disease. Therefore, bed rest is contraindicated, as movement and gradual return to activity promote healing. Red flag symptoms that warrant further investigation or imaging include constitutional symptoms such as fever, chills, or night sweats. Sensory or motor deficits such as paresthesia or urinary retention. Suspicion of infection, particularly in patients using immunosuppressive drugs with recent spinal procedures or endocarditis. Risk factors for compression fracture, such as glucocorticoid use, older age, or osteoporosis. History of drug abuse or malignancy. Other important red flags include age over 50 years, pain persisting longer than 6 weeks, history of cancer, severe or progressive pain, neurologic deficits, and loss of anal sphincter tone. A herniated disc is a common cause of low back pain, often resulting from degenerative changes, trauma, or strain. It occurs most frequently in the lumbar region, specifically at L5, S1, the most common site, and L4, L5, the second most common. Patients typically present with a sudden onset of severe, electricity-like pain in the lower back, often preceded by several months of dull, aching pain known as discogenic pain. It commonly affects middle-aged and older men and is worsened by increased intra-abdominal pressure, such as during coughing, sneezing, or performing the Valsalva maneuver. Associated symptoms may include sciatica, paresthesia, muscle weakness, atrophy, contractions, or spasms. A contralateral or cross straight leg raise that increases pain is highly specific for a herniated disc, though not very sensitive. In some cases, large midline herniations can lead to cauda equina syndrome, a surgical emergency. Diagnosis is based on clinical examination, with a positive passive straight leg raise test being sensitive but not specific. MRI is the preferred imaging modality and is especially indicated in cases of suspected cauda equina syndrome or rapidly progressing neurologic deficits. Additional tests, such as ESR and plain X-rays, may be performed if infection, trauma, or compression fracture is suspected. Cauda equina syndrome presents with bowel or bladder dysfunction, such as urinary overflow incontinence, impotence, and saddle anesthesia. Immediate surgical decompression is required to prevent permanent neurologic damage. Treatment for herniated disc in most cases of low back pain includes scheduled NSAIDs, physical therapy, and local heat application. Bed rest should be avoided, and patients are encouraged to continue normal activities as tolerated. If symptoms persist despite conservative management, epidural steroid injections or nerve blocks may be considered. Surgery is reserved for patients with focal neurologic deficits, cauda equina syndrome, or persistent pain lasting more than 6 weeks despite optimal non-surgical therapy. Spinal stenosis is the narrowing of the lumbar or cervical spinal canal, resulting in compression of the nerve roots and spinal cord. It most commonly occurs in middle-aged or older adults and is primarily caused by degenerative joint disease. Patients typically present with neck or back pain that radiates to the arms, buttocks, and legs bilaterally and often report leg numbness or weakness. In lumbar stenosis, leg cramping worsens with standing and walking downhill, but improves with hip flexion or bending forward, the shopping cart sign. Neurogenic claudication, pseudoclaudication, is characterized by pain and weakness that worsen with walking and are relieved by sitting or lying down. Diagnosis is by MRI, the imaging modality of choice to assess canal narrowing and nerve compression. Treatment depends on severity. Mild to moderate cases are managed with NSAIDs, weight loss, and abdominal muscle strengthening. Advanced cases may receive epidural corticosteroid injections for symptom relief. Refractory cases require surgical decompression, laminectomy, which provides significant improvement in many patients. Motor, reflex, and sensory deficits in back pain. L2 to L4 nerve root involvement causes weakness in hip flexion due to psoas muscle impairment, knee extension due to quadriceps weakness, and foot dorsiflexion involving the tibialis anterior muscle. The patellar reflex is diminished, and sensory loss occurs over the anterior thigh and medial aspect of the lower leg. L5 nerve root damage leads to weakness in big toe dorsiflexion from extensor hallucis longus involvement and foot eversion due to peroneus muscle weakness. There is no associated reflex loss, but sensation is decreased over the dorsum of the foot and the lateral aspect of the lower leg. S1 nerve root compression affects plantar flexion controlled by the gastrocnemius and soleus muscles and hip extension via the gluteus maximus. The Achilles reflex is diminished and sensory loss appears over the lateral side of the foot and little toe. S2 to S4 nerve root lesions cause incontinence and sexual dysfunction, with loss of sensation in the posterior and medial thigh and the perianal region, and an absent anticutaneous reflex. Spondylosis and spondylolisthesis are spinal conditions commonly seen in preadolescent children and athletes who perform repetitive back extension and rotation movements, such as divers and gymnasts. Spondylosis refers to a bilateral fracture of the posterior vertebral arch, while spondylolisthesis is characterized by anterior displacement of one vertebra over another, usually at the L5, S1 level, due to a defect in the posterior arch. Patients typically present with chronic lower back pain that worsens with lumbar extension. On examination, there may be signs of neurologic dysfunction and a palpable step-off deformity in the lumbosacral region. Diagnosis is primarily clinical, based on history and physical examination findings. A short period of bed rest for about 2 weeks may be recommended to see if symptoms resolve. If the pain persists or if red flag symptoms, such as night pain or neurologic deficits appear, imaging should be performed. Treatment focuses on rest, pain control, stretching exercises, and close follow-up. However, if neurological involvement, such as radiculopathy, develops, referral to a spine surgeon is warranted. The prognosis is usually excellent, with most patients achieving full recovery. In cases requiring surgery, possible long-term complications include spinal canal stenosis and intervertebral disc degeneration.